Everyone here to talk about, maybe the most important topic in the federal budget. This year, between Medicare, Medicaid, the Affordable Care Act, CHIP, and the tax breaks, the tax exclusion, the federal government is going to spend $2 trillion on healthcare. That makes it the single largest government program. In 30 years, that $2 trillion is going to be $8 trillion. Our spending on healthcare is going to quadruple. That makes it the fastest growing government program, outside maybe interest on the debt. And every year, we waste hundreds of billions of dollars on procedures that don't add to overall health care, on payments that are well in excess of costs, whether it's for providers, for prescription drugs, to insurance companies, on subsidies to states well in excess of the intended amount, and on other waste. And so that makes healthcare the most inefficient part of the federal government, and therefore the part maybe most ripe for reform. You cannot be a serious fiscal hawk. You cannot care about the federal budget seriously and care about our fiscal situation and not care about what is happening with healthcare, not care about what is happening with Medicare and Medicaid. And that's why I'm so excited to welcome you all to our third annual Health Solutions Summit. You can applaud now. There we go. Our third annual Health Solutions Summit, because we decided that it's not enough to just care about healthcare in the federal budget. We actually need to do something about it. And so a few years ago, we launched a healthcare program to dive more deeply into this issue. And this summit every year is an amazing opportunity to bring together the health policy community, the budget community, folks on the Hill and others, to really just talk about everything healthcare and the budget. Now, a lot has changed since our second annual summit. The drug price negotiations started in earnest. We now have a new HHS and a Making America Healthy initiative. Making America Healthy Again initiative, excuse me, I want to get that right. We have a Department of Government Efficiency that's looking at all parts of the healthcare workforce and maybe at the healthcare spending, fraud and abuse. And we have a major reconciliation process underway right now. The House passed its budget, the Senate has proposed its budget. You can go to our website to see how we feel about it, sneak preview. Not very good, adds a lot to the debt. But within, especially the House budget, there's a significant target for the committee that oversees Medicaid. And so we may see significant changes to Medicaid. We may also see changes to Medicare, to the Affordable Care Act, to tax policies related to health care. There's big legislation that's going to move this year, and healthcare is going to be part of it. Of course, there's also a lot of things that haven't changed very much since last year. The Medicare HI Trust Fund is still hurtling towards insolvency. A little bit later, but fundamentally that imbalance remains. Our national debt is still at record levels and rising rapidly, and our healthcare costs are still at the core of that. For those reasons and more, today's summit is going to focus both on those long-term issues, what do we do about Medicare's finances, and on those near-term issues, what's happening right now on the Hill and the administration with Medicaid, with these other programs. And I'm really excited to introduce one other new thing, which is that we have a new director of health policy, Anna Bonelli, who has worked at CMS, has worked at GAO, basically that's got 3 letters and has done healthcare. She's been there. She spent time on the Senate Finance Committee. She knows Medicare and Medicaid, and many of you know the health community is so bifurcated, it's hard to find somebody that knows both. It's easy to fake knowing about one, but like actually understanding both is, it's just a real treat and a pleasure to have been able to work with her so far. And I'm going to introduce her to come up now and MC the rest of today's summit. Thank you all.
In 2024, the federal government spent $910 billion on Medicare, and CBO projects that in 10 years, we will be spending $1.7 trillion. Even in DC, that's a lot of money. Last week, CBO published their long-term budget outlook, and it had some sobering projections about spending on federal health programs. Medicare will account for 90% of the increase in health spending across federal health programs. In other words, if you look at just the increase, so just look over time, and the increase in health spending for the federal government, 90% of that increase will be in the Medicare program. CBO also projects that the Hospital Insurance Trust Fund will be exhausted by 2052. And I don't know about you, many of you will not be qualified for Medicare at that time, but I will, and I really want it to be fully funded. So as you can see, all of us policy nerds here today have our work cut out for us. So before I turn to our panel, to talk about these issues. I just want to remind you of a little bit of logistics. On your seats, there are some cards, and if you need pens, please wave, and someone will help you, or just help your neighbor. Write down your questions. We will have people circulating so that you can ask questions of these of our expert panels today as well. With that, let's turn to our panel. Analyst at the Ms. Gannon Center. Leslie Gordon is joining us from the Government Accountability Office, where she is a director focusing on Medicare. And Jim Capretta is a senior fellow and Milton Friedman chair at the American Enterprise Institute. This distinguished group of experts will be moderated by our former CRFE colleague, Josh Gordon, who now advises the healthcare team at Arnold Ventures as the Medicare and Commercial Crisis Fellow. Josh, take it away.
All right, thank you. Okay, so you know the logistics, you know our panelists. I'll say that it's nice to be up here, sitting here and not having to worry about those logistics. How much Diet Coke there is, if we're running out of quesadillas. These are all things that become very important when you're putting on this event. So I really appreciate that CRFB does this. Their staff works exceedingly hard to get this done. So thank you to them, and thanks to them for inviting me back to lead this panel. We're going to hear from our panelists. They'll each take about 5 minutes to talk about the things they care about when we talk about Medicare sustainability, and then I'll ask them some questions, and then we will get to the audience questions. So we will start with Leslie.
Thank you. Hi. Okay, we'll get the mic leveled out here in a minute. I'm Leslie Gordon. I'm a director in GEO's healthcare team, and I lead our Medicare body of work, which extends long before my tenure. So we've been looking at Medicare issues for as long as GEO has existed. And Medicare appears on GEO's high-risk list. It's a founding member since 1990. We think it's absolutely essential that the federal government and all of us focus on the sustainability of the Medicare program, as it has implications for the federal budget as a whole, and it says implications for the federal budget as a whole. Sustainability of the Medicare program isn't just important for the 68 billion beneficiaries and those of us who hope to age into it. It's vital for the sustainability of the federal government, as our colleagues have mentioned. Every year, GAO puts out a national report on the nation's fiscal health. No surprises here. This year's report says the federal government is on an unsustainable fiscal path. GAO projects the debt held by the public will grow faster than the economy each year, and if the current revenue and spending are not changed. This unsustainable path and projection is consistent with CBO's projections, as well as those of the 2024 financial report put up by the US government. At the end of 24, debt held by the public, I have a little different number than you, Anna, was 28.2 trillion, 2 trillion higher than the prior year. And 3 months later, at the end of calendar year 24, it had increased by $500 billion to 28.7. As you know, debt is an accumulation of our annual deficits. And normally we experience deficits, or we have in the past experienced deficits due to wartime, due to shocks, due to pandemics. We're experiencing deficits in times of economic growth, which exacerbates the issue. We've talked about the deficit being 1 trillion in 2024. Our spending was $5.9 trillion. Social Security, responsible for 1.5. All federal healthcare spending, I have a little different number than Marc, was 1.8 trillion. So Social Security and Medicare and all federal spending on healthcare programs is more than half of the spending for the federal government. Since 2017, the GAO has suggested that Congress develop a strategy to place the government on a sustainable path. There are a few elements that we recommend be associated with that. Establishing fiscal rules and targets to address imbalance, address the financing gap in Medicare and Social Security, pursue opportunities to improve fiscal responsibility, mainly focusing in on improper payments, and considering replacing the debt limit. Turning to Medicare, the trustees estimated that federal Medicare spending will grow at a faster rate than workers' earnings and the economy overall in the long term. We know that spending is driven by the increased percentage of the population that is covered under the Medicare program, and in 5 years, about 20% of us will be Medicare eligible. But it's also driven by the increasing cost of healthcare overall. There's an increased cost per beneficiary in the Medicare program. The financing gaps that need to be addressed, you heard about the depletion of the trust fund in Part A. In Part B, the increased spending is really burdening the beneficiaries. Every year, the Part B premium is based on spending in the program, and so premiums go up for seniors. And not only do their premiums go up, but then their out-of-pocket costs go up as well if they're not a Medicare Advantage. GAO has 64 open recommendations to the administration to improve the administration and sustainability of the Medicare program, and we offer 3 matters for congressional consideration as well. These recommendations address some approaches to realizing cost savings, identifying and recouping improper payments, improving oversight, and ensuring better quality of care for beneficiaries. Taken as a whole, GAO's recommendations won't touch the financing gap, unfortunately. We all need to look for improvements, big and small, to bridge the financing gaps and ensure the program's sustainability. Thank you.
All right, thank you. Now we'll go to Jim.
Well, thank you. Very pleased to be invited to be part of the panel, and it's certainly a very important conversation about Medicare. It's obviously a very important program for the public, and to how the broader health system operates as well. So it's central to all of the matters that Marc Goldwein talked about at the beginning, how to get our fiscal situation under control, but also how to improve American healthcare, which has lots of problems in it. Let me just start with a couple of preliminary comments. One being that, this is a fiscal conversation and a healthcare conversation, and I'd be a little bit off if I didn't sort of note the context a little bit in which this is happening. It was mentioned by Marc that they are working on bills on the Hill. From my perspective, it seems like we should be recognizing that even if they did put Medicare into the bill, which it seems very unlikely they'll put much in, but if they did, it would be largely in service of probably a bill that's going to make the system, the whole situation a little bit, maybe a lot worse, depending on some decisions that are made here in the next couple of months. And so, it's like we're in this gigantic deep hole. Both parties have dug it. And it's one party's turn to have another whack at it, and they're going to dig it, 20% deeper, and then say, okay, now we got to get out, And I'm not sure that's the best way to proceed at this point. Second observation is that trust funds become important in this conversation because they're something that resonate with politicians and they resonate with the public. Now, for those of us who follow these things closely, we understand the trust funds are essentially like accounting devices. They're supposed to be intergenerational devices to help send signals to the political process about, hey, something's wrong here, let's get it back in order. We hear a lot about the HI Trust Fund, its status because of that. But of course, HI is about 40% of Medicare at this point and dropping. And so much of the expenditures are not in the HI Trust Fund, and very few people really understand how the other trust fund works, Part B, which is 75% financed out of the Treasury, out of subsidies that come out of it every year. And the subsidies are set to make Medicare whole no matter what. So whatever is spent, it's always solvent. It's one of these funny, they put this big, thick trustees report out every year and it says the same thing every year. Hey, it's solvent, don't worry, And it's by definition, it's always solvent. It just draws as much money as it needs. And the numbers are very startling. In 1990, And some people in the room, I won't name any names, we're working on these things in 1990. The draw out of the Treasury for the SMI Trust Fund was 0.5% of GDP, which was a lot of money. Now it's 1.7, so it's tripled. And in the trustees report, it's headed, in a few decades, not that long, up to 3% of GDP. So every year you're going to draw 3% of GDP out of the Treasury to subsidize the Medicare program. Initially, it was supposed to be 50-50 split. Now it's 25-75 with the premiums. I'm not sure there's anything to be done about it. I recommend we do something about it. I'm just worried that if we're going to use trust funds as the signal about fiscal distress, this is a massive draw on the Treasury. It's fundamentally related to why we have a fiscal problem. It's almost the number one issue. And so if you want to send signals to the political process to start doing something, you might need to take a look at this and figure out how to make it send signals about, hey, we can't keep doing this forever, okay? Now, to Medicare specifically, it affects the entire health system. It's the biggest single player in the system. I mean, it's not a single payer, single player, in the sense that the rules it sets affect how lots of things operate. So if you can get Medicare right, you're going to have some good effects. And some things have gotten better. All the regulated payment systems now are mimicked in all kinds of corners of the health system. In some degree, that's held costs down a little bit relative probably to where they would have been. Not great, but also, we take the progress where we can get it. I have a lot of things I would like to say about how to fix this. We only had 5 minutes, so I'm not going to be able to go into them all. The conversation, I hope, will draw them out. Let me just mention 2 or 3. I think we should put into Medicare automatic adjustments so that we don't get in a position where we're always chasing our tail about how to get it solvent and sustainable. We ought to make some goals fiscally about how much we are willing to spend and then adjust things accordingly on a bipartisan basis. Taxes, premiums, benefit design, and what we pay the providers should all be on the table, and adjust them all very modestly going forward. Real Medicare spending can still go up a lot, and you can still keep the system solvent and affordable if you just make these adjustments built in and automatic so the political process, which has trouble moving fast, doesn't have to try to deal with it all the time. We need to have more standardization of the benefits and more simplification of the benefits. It's time to get to a more simplified benefit system that has adequate coverage and is the same in MA and the traditional program. So they're much more comparable and people can compare, which one is actually providing better value. Same for the supplemental benefits offered in the private sector. Lots more to say, but I'll stop.
All right, thanks. All right, Lawson.
Thank you so much to the committee for having me. I once mistakenly called CRFB budget hawks to Marc in conversation and realized that that's just the Twitter handle, which may have revealed how too online I am. But really, thank you, Josh, Jim, Leslie. I kind of want to set maybe some background for the way I think about healthcare. Jim and Leslie do a great job of kind of discussing the main question about spending, which is on healthcare, which is can we afford it? And I think that's a helpful question because you have a lot of big numbers thrown around. $1 trillion that we're spending on Medicare, $2 trillion total on healthcare. And I think there's a kind of a question under that isn't asked as often, which is that the right amount to be spending on healthcare? And I think the answer is we don't know. The only way we can really answer that question is, first, can we afford it? And then secondly, how does our spending compare to other countries? And so I'm sure you've all seen the chart. With the dots in the countries, you see the US spends way more than anyone else, and we simultaneously have, among those countries that spend a lot on healthcare, we also have the worst life expectancy among those countries. This is a chart that's thrown around before, but also I think it's become even more common with the Make America Healthy Again agenda. You see that chart a lot. And I think that it's helpful to base some of the conversation in that because what is actually driving the life expectancy? The reality is, particularly for the Medicare population, what's driving it is an increase in the rates of chronic disease. Conditions that are treatable. It's treatable deaths that are ultimately driving down our life expectancy. And so I think when we think about Medicare, one of the main questions we have to ask is, how do we actually drive
Medicare spending to the types of interventions that save lives. Because ultimately, I think that's the purpose of the Medicare program, it's how do we save lives. And I think there's an important way to look at this, which is who are the types of doctors that deal with chronic conditions? The reality is it's primary care doctors. And that is not where Medicare funding is primarily going at the moment. And so we can drive patients to lower cost centers for care at the same time as prioritizing the type of care that patients need the most. If Medicare invests in primary care infrastructure, which I think is a really important part of Medicare sustainability. I think that there's a couple of different policies that we can get into there, but for now I'll leave it at that.
All right. Just a reminder, you can write your own questions and someone will come around and pick up your note cards. But I will take the moderator's prerogative to ask a few of my own first. And let me start with this kind of general question. There's a fair amount of sort of public bipartisan posturing over the idea that Medicare should be off the table. And this was during the last administration, it's during the current administration. I should note, because we are at a CRFB event, I'm required to say that CRFB believes nothing should ever be off the table.
More borrowing. More borrowing.
More borrowing should be off the table. Yes, thank you, Marc. Other than that, nothing should be off the table. Of course, there are different ways to interpret this posturing. So I'm going to ask you all how you would interpret that in order to do some of the changes to Medicare that I think we all agree should be done. But let me start counterintuitively. Is there anything related to Medicare that should be off the table? And then tell me how you would interpret this question for current policymakers. Interpret the general question. Lawson, you want to start?
Yeah, so when you say off the table, you mean things that shouldn't get cut.
Yes.
When we're talking about, yeah. It's a good question. I think that in the Medicare program, I'm going to go to maybe an issue that isn't typically talked about, which is funding for residency programs. I think that there is a lot of conversation on the issue of the doctor shortage, and I think few people realize that Medicare actually plays a role in the supply of primary care physicians and actually the kinds of doctors the United States produces. And there's on the menu of options that was initially proposed, one of those would have cut what's called graduate medical education funding substantially. I think there are a lot of savings and efficiencies we can have, and we can get maybe more into the details on the financing of graduate medical education. But I think there is growing momentum towards sort of a posture of we don't need to provide any subsidies to hospitals or teaching programs. And I think that a subsidy is helpful, not because I think hospitals don't have enough incentive to fund and create teaching programs to create doctors. I think that when we have a shortage, we need to find creative ways to address that. And so I would say that ensuring that we have sufficient levels of funding for graduate medical education should be something that's a priority for policymakers.
And do you want me to come back to you for the converse? Do either of you have something to add to something that should be off the table?
Well, maybe I'll just address the point
Sure.
a little more broadly. I'm basically in the view, of course, that everything should be on the table, that nothing should be off limits for thinking about how to reform the system. I mean, if I were, advising people operating in the political environment, I'd say there's plenty of things that can be done in Medicare that would improve it and can be sold easily as being things that would benefit the population that rely on the program. And therefore, why take it off the table? Because there could be win-win situations where the taxpayers win and the beneficiaries win. If there's enough money to be saved, if you believe, as I do, there's lots of ways to save money in Medicare, split it a little bit around so everybody wins, right? The taxpayers win and the beneficiaries win. So I think I wouldn't take anything off the table. By the way, I don't think a lot of it will be off the table. I think the administration, anyone who's been reading the news lately knows that they seem to have a lot of energy, and so they're going to be active administratively. Right? So what does that mean exactly in the Medicare context? I think it's all TBD, but they're going to do some things, and so some of them probably will save a lot of money. And so I don't think it's really off the table. They mean off the table like, we don't want the Democrats to attack us for cutting Medicare benefits, so they'll avoid whatever they have to avoid that kind of attack.
The GAO's position would be nothing should be off the table. There's probably room to find efficiencies in every corner.
And Lawson, you and I worked on something that is a win-win, like Jim said, the so-called site-neutral payments. Do you want to talk a little bit about why that's a win-win and can also fit under this conception about not cutting benefits?
Yeah, and I think you hear the rhetoric from the administration that Medicare should be off the table. We don't want to cut Medicare. You hear the same thing about Medicaid, and I think there's so much nuance lost in conversations when you just use the word cut, because a cut to Medicare in the example of site-neutral payments, that's really the losers in those situations are big hospital systems. The winners are beneficiaries and ultimately the federal government. So it's a cut to Medicare in a sense, in that sense, but it's not a harmful. There's a lot of Medicare things, Medicare reforms that wouldn't harm beneficiaries. In the case of site-neutral payments, I think it's important, particularly when we talk about the trust funds, because you see sort of a pushing back of the date of insolvency for the HI trust fund. But as Jim mentioned, when it comes to Part B, outpatient services, they're going to keep funding that no matter what. And when it comes to outpatient services, that's where site-neutral payments comes into play, because Medicare pays hospitals double what it would pay for a service at a physician's office. And it's created this incentive to consolidate for these big hospital systems to buy up independent primary care, independent clinics, and then begin billing for essentially double, triple, sometimes quadruple for the same service provided in the same way. And so when you actually standardize, make those payments site neutral, the benefit is the benefactor is ultimately the beneficiary who pays less out of pocket, and then also the federal government saves as well.
And Jim, you mentioned how Medicare is sort of a leader for the overall healthcare system, and this is one of those areas where Medicare has this weird payment policy, and then that spreads to the commercial market and leads to even more kind of waste and excess payments and poor incentives.
Well, a big one being, of course, is incentivized, very likely, empirical evidence shows it is incentivized consolidation. So, basically, if every, hospital system can make more revenue through this pathway, they have an incentive to buy up as many of the alternative sites and put them into the higher revenue pathway, and you just get a lot of integration that is not helpful to anybody who's trying to get lower pricing in service delivery, and a lot of employers suffer from that and so on. So it's part of a larger phenomenon of rewarding pretty heavily capitalized, built up health systems dominating a lot of metro markets, and I think that's part of our problem.
I think that the consequences of that, of Medicare's payment policies, is the squeezing out of lower cost settings for care. Medicare sustainability relies on paying less on a service-by-service basis. You need to be able to direct patients to lower cost scenes for care. But if those independent providers that can offer lower cost services at the same quality levels are disappearing as a result of consolidation, as a result of paying specialists more for care than we pay primary care, for not being able to correctly identify what a primary care visit should cost because it's not as a procedure by procedure. Those issues contribute to Medicare's unsustainable track.
Jim mentioned that the current administration has a lot of energy, and I guess it's reasonable to say some of that energy is directed towards finding waste, fraud, and abuse. And Leslie, I know the GAO does a lot of work on improper payments. I think it might be helpful for us to understand what aspects of those improper payments are waste or fraud or abuse versus maybe more kind of benign reasons that all add up to a lot, and then maybe give us some sense of what fixes you could do in the improper payment space that might save some money.
Thanks. Let me be clear that the estimates around improper payments have nothing to do with fraud. You cannot take the improper payment estimate and know anything related to fraud. We estimate improper payments, or rather CMS has contractors that estimate improper payments in order to get a sense of how well is the program being administered, how well is the service that are provided actually being provided to the right person for the right condition at the right time and by an eligible provider who's following Medicare's conditions of participation. So, you know, the exercise of estimating proper payments is a measurement exercise. We sample a stratified sample of all of the services in fee-for-service. Then they look behind coders and certified reviewers look at the medical record associated with those. We find that most improper payments are in the category of insufficient documentation. What does that mean? It means that documentation was provided, but it wasn't enough to fully verify that it was the right service to the right person at the right time. And it can be as simple as the physician didn't sign the notes or didn't sign the order. And when you're talking about more complicated areas, referred services, for example, then you've got to go back to the referring provider to get the documentation. So it's an exercise in really understanding how many controls are in there and are people playing by the rules. But it's sampled across the number of services to generalize to all of the payments in Medicare fee-for-service, for example. And I could go on about Medicare Advantage, but I won't.
Next question.
Okay. You know, but it tells us nothing about fraud. To understand fraud, you need to look at patterns. You need to look at providers and the level at which they're billing, because fraud is the willful misrepresentation of something in order to gain something, usually money, but it could also be other access. But fraud is you have to prove intent in a court to be fraudulent. Are there people out there sort of skirting the rules? Perhaps, yes. And do they get investigated? Yes. There is an entire program integrity system at CMS that is reviewing claims before they get paid, that is following up, that is sampling. There is an alphabet soup of contractors who look at the claims. I would argue they might not be looking at enough of a sample. Last year it was 64,000 claims out of 1 billion fee-for-service claims. And then they extrapolate from there. Next year it's going to be, I think, in the 30s, like 35,000. They're reducing their sample size. You know, so we are very pro estimating proper payments, doing your reviews, having your contractors there, because not only do you get more information about where the potential areas of problems are in terms of documentation, but you also get you also have a sentinel effect. There's somebody looking over the provider's shoulders to make sure they're doing the right thing. But, you know, improving it, we have a standing recommendation that CMS look at its documentation requirements across the Medicare and Medicaid programs. We did this work back in 2019 and found that for the same service, for potentially the same beneficiary and the same provider, there could be 2 different documentation requirements in Medicare and Medicaid. That introduces a fuzziness into the system. It's certainly not efficient. It certainly doesn't help. You know, so it's hard to know, like it's hard to know are we spelling the right amount. It's hard to know, is a documentation requirement the right amount to truly measure what is improper or wasteful. It's an example of one of those.
Thanks. Okay, so I think that is a good segue to Medicare Advantage, because you have probably a combination of all of the waste or fraud or abuse. You can find all those things in different places, and this is something that I know CRFP has worked on a lot, and Arnold Ventures works on it a lot. So why don't we talk a little bit how what reforms there could be in Medicare Advantage. Let's start small and then maybe end big. Just so everyone knows, if you want to learn more about this, CRP's website has a great new blog estimating overpayments in Medicare Advantage at $1.2 trillion over the next 10 years. That means we are paying that much more to provide health insurance through MA than we would if everyone was in traditional fee-for-service Medicare. So that even in Washington is a large amount, as Anna said. So let's talk a little bit about maybe some of the small things we think need to happen to improve this in Medicare Advantage, and then maybe we can go to some bigger reforms. Who wants to start?
This is an awfully big topic. There's so many things to say about it. Well, I guess, first of all, in terms of the very large estimates about the overpayments to the MA plans, I mean, I totally agree. They're overpaid on metrics of how to assess, those plans relative to fee-for-service. They are getting more revenue. I think that people should be careful and say, well, there's an impression left that we could easily take $1.2 trillion out of the system, shove everybody into fee-for-service, and there'd be no system response. That all that money would be gone, and then the taxpayers would all save, and the fee-for-service system could accommodate all those people at the lower reimbursement levels, and everything would be just fine. Nobody would lose anything. It's all just sort of waste. I mean, that's not very likely how this is going to work, okay? I mean, if you took it all away and they went into fee-for-service, the pressures on fee-for-service to spend more would be immense, okay? So there's a reason why people are in Medicare Advantage, and the main reason is they get better benefits at lower cost sharing, okay? And it's a simplified benefit. So it's complicated to stay in fee-for-service these days because of the number of premiums you have to pay. So I worry a little bit about the impression of the big number, and it's easy to get, okay? Having said that, there's two things going on here that are pretty obvious and should have been fixed a long time ago. One being that if you put the MA plans themselves into the position of determining their own risk adjustment factors, they're going to get more money. I mean, it's just so obvious. It's always been the case, So there had to be a system where they were sending in their data, and CMS decided what the risk adjustment payments were. But that's not how the system works. They send in the data, and it automatically triggers their risk adjustment payment. I mean, that's what's going to, or especially over many decades, it will get worked until they get as much money out of it as they possibly can. Second thing is you can get away from this if you went to competitive bidding. I would say the absolute one thing over the years that I know the plans despise and will fight to the death, which means it's the right thing to do, is competitive bidding on the premiums for a standardized benefit. They do not want to disclose what their premium is on the exact same benefit relative to a competitor. That's the last thing they want anyone to know. Because then you can say, gee, why are you charging $25 more a month for the same thing this plan is charging, And so they don't want that, which is why it should be done, okay? So I think if you did two things, make the final decision on risk adjustment, move it out of the plans submitting data that automatically triggers it to a system where they submit the data and there's a screening system that homogenizes across all the plans and CMS decides what the risk adjustment is. That would be the first thing. And then the second thing is put them on competitive bidding. On a standardized benefit, it's exactly the same as fee-for-service.
Any of you, either of you?
I don't know if I have too much to add to what Jim said. I think he's exactly right. I think in general, we can save tens of billions just by looking at the risk adjustment portion of this. And I think that among the things being considered in ways to save on healthcare, I think that MA overpayment should be a part of that conversation. It doesn't seem like Medicare is going to be a part of that conversation, but it 100% should be.
I'll chime in on the Medicare Advantage improper payment rate and how we look at that. Last year it was $19 billion in improper payments to Medicare Advantage plans, or 5.6%. Nothing to see that. That that assessment has to do with looking at the medical record documentation from contracts of beneficiaries on contract, under specific contracts to MA plans, and determining whether or not the documentation supports the diagnosis or the diagnoses that underpin the risk adjustment. So that 5.6% is about not having the documentation to show that the individual should have been paid at the rate they were paid at. And yes, there are adjustments, there are overpayments and there are underpayments. It nets out to about $15 billion. But there's room to go after and do a better job of overseeing the payments to the plans, even in the current structure. And we've pointed out through our work looking at the risk adjustment data validation contractor. So there's two approaches. There's two different timings on it. There's one that does the annual estimated improper payment rate for MA, but then they have a review to go looking for improper payments that can be recouped. CMS is still looking at 2018 payment year Medicare Advantage rates. So there's room to improve the timeliness there.
Did you want to add something else? Okay. Let's talk quickly about the other part of Medicare, and then maybe we'll get back to this. In fee-for-service, one of the things that the fee-for-service system still does is determine the payments we pay to hospitals and doctors. And the doctor payments seem to be stuck in this loop where, I mean, Jim, you and I have been around maybe longer than some other people here, where every time we make a change to how we pay doctors and set the level, you wind up having to come in every year and fix that because the doctors complained about not getting enough money. We were supposed to have permanently fixed that in 2015, and yet we're back at a situation where this is happening again every year. The physicians come to Congress at the end of the year and say, we're not getting paid enough, we need to get paid more. At the same time, MedPAC looks at accessibility that patients have to doctors, and so far, even though we're paying doctors less, according to them, under these formulas, beneficiaries still have access. So I guess it's time to start thinking about how we should make a permanent fix to physician payments, which maybe will last another decade, which I guess is something. But where would you start when you think about how to fix doctor payments?
This topic is very big. I would say that there's all kinds of good ideas about how to make improvements to the physician fee schedule and the bonus payments, and maybe how to maybe get rid of NIPS and replace it with just more alternative payments. So there's lots of ideas and thinking around that space, all of which I'm sympathetic to and agree we should pursue those as a way of working the dials on the existing system harder in a better way. I think there needs to be, though, some, I think we have an opportunity probably in the next couple of years to try to put one other bigger idea in there that might take some of the pressure off just the fee schedule as a way of compensating physicians in fee-for-service. And that is to move to more of a model for people for their primary care and for their chronic care management, of which basically the entire beneficiary population, fits into those categories. Move them to the degree it's possible, and I think it is possible for a lot of care, some of the payments out of fee-for-service entirely, and move toward a much more of a standardized, population-based model, people call it, or per member per month kind of thing, where a primary care provider will, if the beneficiary elects them as their primary care provider, they get paid some fixed amount per month to provide all the normal things that are needed in primary care, chronic care management, preventive services, electronically, in the office, by email, touching base with their nurse practitioners and so on. Make it much more preventive, population-based care on the primary care side, and take it out of the fee-for-service model. I mean, we're still sending in, $28 claims all the time for all kinds of things that it would be a lot better just to have everybody in a population-based model that was regularized and standardized, and maybe have some level of beneficiary selection involved too. So I think that's something that might, catch on if people, it's sort of like accountable care organizations in a slightly different way. But I think it could really take some of the pressure off of the debates that go on in the fee-for-service fee schedule, which are complicated and, have a different set of problems associated with it.
Yeah, no, I think Jim is exactly right, and the focus on finding a way to better compensate primary care doctors. I do think we need to rethink how we do it. And so I think there's two ways. One is as Jim mentioned, prioritize these programs like I think ACO REACH does some of this in terms of the primary care adjustments. I know AHEAD, another state of my program that is trying to move more to a capitated model for primary care. But the other is just to do a better job valuing primary care when we do it on a fee-for-service basis. Because right now when it comes to specialists and other sort of services, a procedure like a mole removal has a certain dollar code attached to it. The kind of population health, the preventative care, primary care that Medicare beneficiaries desperately need isn't as easily procedurized. A lot of it is really mental, and those primary care really has like 5 buckets or so that you can really place into what a service is. And so being able to better value primary care services according to their actual value to the population, which is extremely high, I think needs to be a consideration when it comes to the schedule.
Okay, I think we have time for maybe a couple more questions. So we haven't talked about prescription drugs yet, and so I thought it would just be worth checking in on how everyone thinks the IRA negotiation provisions have been implemented and where they think they're headed, and whether there are some immediate tweaks that Congress should be thinking about right now to that to get us to more prescription drug savings.
Well, I think overall, the provisions of the law are working as planned. Let's put it that way. I think it was implemented pretty consistent with as it was advertised. So I think to that degree it was good, they followed through on sort of how they said it would play out. And I think the industry in a certain sense was relieved that that's how it played out. On the other hand, I don't think it delivered a huge amount of savings. If you look at sort of where the prices ended up relative to sort of where the market was sort of delivering the products anyway, it's a little bit of savings maybe, but not a huge amount, I think what's missing from this is a little bit more clarity about the objective up front, and I'm not sure this administration and this Congress will do it either, which is to just be more clear about sending signal to the industry on how it will measure, the products that are the most valuable and clinically advancing products that are coming online. They talked about it, as part of the criteria, but it's not sort of number one objective. And number two, I don't think it was clear totally where they'd find the data and who they'd trust to make that kind of an evaluation. So I think this idea would be to designate 3 or 4 academic institutions as the main contributors to figuring out what is the actual clinical value, additional value over the previous standard of care of some new innovative drug. I think that, and it could be based on 3 or 4 years of experience too, instead of waiting, just doing it at the time of applications. I think that kind of data and reliance and making that the objective sends the right signals to everybody. That if you really come up with a whiz-bang product, you're going to get paid well. But if you don't, then why are we paying so much? That would be sort of the basic message. And I think a little more clarity in the public messaging that is the objective, I think would be beneficial for all concerned.
I think, I agree with Jim on the drug negotiations part. I do think that policymakers should also look at kind of the key bottleneck in this is really the ability to get generic drugs to market. And patent reform, I think, is a big part of that. Being able to reduce sort of the schemes that brand name drug makers use to prevent judgment coming onto the market. There was a great patent reform bill that was included in the year-end health package, Senate Bill 105, sponsored by John Cornyn, that didn't end up obviously passing, but I think there's opportunities there as well to actually lower drug costs.
All right, we have a little more time than I thought, so that's good. So just so you know, I'm reading everyone's questions and I'm trying to weave them in. So I haven't been doing this all on my own, but there are a lot of, let's say, pessimistic questioners out there. They aren't sure anything will ever get done. I, however, am super optimistic that something will get done. I talk about healthcare a lot with people who don't know about it when I'm teaching in classes, and I say that if every other country has figured out a way to deliver the same or better healthcare at less money, there certainly is something that can be done here, and that is why I'm eternally optimistic. So that's just a general thing. But let's, and I know the next panel will talk about immediate discussions on the Hill, but I think it's worth hearing what these panelists say about what they think maybe the number one thing that they hope Congress puts in, and that is realistic for Congress to put in the next couple years on this. And it could be one of the issues we mentioned, or it could be something else.
Yeah, I can start. I do think that we have to look at where we can actually drive the most savings for beneficiaries and for the sustainability of the program. And I do think site neutral payments is perhaps the most tractable and provides the largest amount of savings when it comes to things that are on the table. Senator Hassan and Senator Cassidy released a framework that I think is workable, that would kind of answer the question that many folks on the Hill were asking about site neutral payments. If you take money away from hospitals by making these payments site neutral, what happens to all these rural hospitals that are on the brink? And you know, the framework that was proposed would actually take some of the savings and sensibly reinvest it into hospitals that need it, and also kind of stagger that based on, you know, is a hospital in a rural area a high needs hospital? Are they performing a core line? Do they have like a core line of service that they're performing, whether it's a burn unit or obstetrics? And how do we make sure that we keep those service lines open? And so I think that framework is something that when I think of the next 2 years, I think that that's workable and tractable, and it answers a lot of the questions that the industry is asking about site neutral payments. So that's what I would say.
I'd love to jump in and say GAO is team site neutral payment too. But I think we have another recommendation around accountability, and that is that CMS should seek legislative authority to have recovery auditors do pre-payment reviews. They did a pilot test of this, and let's stop the improper payment and the waste before we actually pay it.
I have a thought about a system change. Is it realistic? I'll let the audience be the judge of that. But I think if one is looking for something that really makes a big difference, that kind of changes the dynamics in the system and really has some potential to lower pricing, you really just have two options. One is to have the government come in and just say, we're going to pay a lot less, both in commercial and private insurance. So really sort of here's the rule, and you can't exceed it, okay? I think, 80% probability that happens eventually somehow in our country. I don't know when, but that might happen at some point. I'm not in favor of that. I'd rather have, because I think that has some downsides to it, I'd rather have, and this seems far-fetched, some of the big players come forward, or new entrants come forward and say, I can do better at a lower price. Does that ever happen in healthcare, right? I mean, does anybody ever come forward like they do in other markets and say, you know what, I could actually deliver all that fancy whiz-bang care at 80% of what you're being charged? Why doesn't that happen, right? There's 1,000 reasons, okay? But the basic one is the incentives are all misaligned, okay? And to break that and make it so that someone, even a new entrant, a new startup, imagine a new hospital system comes online that says we're going to be the low-cost hospital, right? Why would they do that? It would only happen if there was migration toward it from the big players, from the employers and the workers who get their coverage through their employers. Said, yeah, I'd rather have lower priced healthcare if it's high quality. And so how do you incentivize that? The main one is you've got to give the consumers some ability to see it and opt for it and win when they do. Okay? And that's not easy to do, it's complicated, but right now the entire system is built to make that opaque and impossible. Okay? And so how do you do it? I think I'd start with standardized bundles of care, pricing on it, and whenever a patient says, I'd rather get my surgery for $4,000 instead of $10,000, which would be possible, they get to somehow they get some benefit from that $6,000, not just the insurance plan. Okay, so I think that's really, if you want to think big, you need some kind of dynamic like that in the system to operate. It's hard to do because you need standardization. You got to make it easy for people to see what's being priced, what way, why, and that requires regulation. But I don't think we're not obviously shortage of regulators, so let's do the regulation the right way. I think it's really important.
I just want to say I share Jim's kind of thoughts on the need to get consumers and employers involved in this space if we actually expect to lower costs. But I will say that we know what the lower cost providers are. So we know that ambulatory surgery centers can provide the same surgeries at lower costs in the hospital system. I actually got into healthcare because I'm from South Carolina. And in Orangeburg, South Carolina, rural South Carolina, we were working with two doctors who wanted to build an ambulatory surgery center. We were working with them because the big hospital system, which was 20 miles away, was using the certificate of need process, a state regulation that requires a new incumbent to request permission from the state to build a new hospital. And they couldn't build. They wanted to provide lower cost care in a rural part of my state, and couldn't do it. So I think part of this is, yes, I think the administration seems focused on price transparency, getting consumers involved, but I think we also have to be able to recognize that it's going to take a long time for consumers to respond to market forces in healthcare. A very long time. Regardless of how good our price transparency is, it's very difficult, even when you provide cash incentives, for patients to actually shop for care. So we need to be able to focus on making lower cost care more available. And I think that comes down to either paying more for it or adjusting the payments, so we're paying hospital systems less for providing more expensive care at the same quality as an independent option.
And I'll just add to that, I had lunch this weekend with a physician friend of mine who operates an independent cardiology practice, and they have they own a surgical center, but because of site neutral payments, they're under pressure on a monthly basis to sell that to a big hospital system, and because the incentive is still there, that if all of a sudden the hospital system buys it up, they can charge more for those same surgeries. So you have to work on it from both ends, I think, to make that work. Let me ask the same question I just asked, except have it focused more towards the administration. Obviously, there's some uncertainty about how the administration will use the agencies, CMS, HHS, but if you were advising them on the one thing they could do legally, regulatorily, or whatever the word is, what would that be?
Well, I guess I'll go. I mean, I think they have authority it's time to do some improvements on risk adjustment in Medicare Advantage. So I think if I were them, I'd go quickly and get that done early in their term, because it'll be controversial and somewhat painful. And so they may as well use some of the political capital they have now to kind of get it done in a way that just rationalizes a little bit more how that system operates, takes some of the noise out of it, stop the, nurses visiting people's homes, knocking on their door to see how sick they are, and that kind of stuff. And kind of make it a more rational system and take the decision-making, the final arbitration of who gets to decide what the risk adjustment factor is by plan, make that more CMS's call based on all the data that they can visualize across all the submissions. I think they should move quickly to do that. They probably have the authority to do it.
Yeah, I agree with that. They do have the authority.
Yeah, I can go next. Well, I guess I can start out with maybe what not. And I would say one way that I don't think is important to Medicare sustainability is laying off employees in labs. I just want to acknowledge that I'm sure there's folks here who may have lost their jobs this week. And I think it's really important that we put some of these things in context, because HHS is ultimately an agency that is iterative. It started out here, and then every new department, every new employee was created and hired to respond to a problem. And so when you take a bludgeon rather than a scalpel to an agency like that, there's going to be gaps. And so I think one way not to do this is to create those gaps. In addition to that, the actual inefficiencies, the kludge that kind of grind, that ruins the gears of bureaucracy is often in statute, it's in guidance. It's not the people themselves, it's the rules that they're operating under. So firing people without changing the underlying rules that oftentimes drive the inefficiency, I think is poor strategy, and ultimately is going to make HHS less efficient. And so I just want to say that. Also, in addition to that, I think CMMI, of all the agencies that are trying to drive transformative change, I think, I'm glad that in some ways they were spared. I know that 25% of their staff were laid off prior to this week. But with that said, I think that there's still potential to drive change at CMMI, and I think it's important that, it seems like the administration recognizes that, but I would just underline the importance.
I'll just read it. GAO has 64 open recommendations for CMS to consider to improve the Medicare program.
Any last words on that, Jim?
No, I think that's good.
I mean, I think that pretty much covers the gamut. I think we helped educate the public that is here, and hopefully you all will visit all of our websites and learn more about ways to reduce the cost of healthcare and make Medicare more sustainable.
That was fantastic. Thank you all so much. I learned a lot. That was very weedy. So lots more conversation to come. I've been reminded that we have a hashtag that I want to share with all of you. So while you're on all your platforms, not that you should be on them right now, but as we're doing our thing and you're on your platforms, please use the hashtag Health Solutions 2025. All right, that'll be fun. Okay, so we're going to take a 20-minute break. Everyone can enjoy some refreshments in the back. In 20 minutes, I'll call you all back in, so that'll be about 3:30, I think. All right, so enjoy. Write down questions as you think of things. We'll bring them up and ask your questions. Let's think about, let's get into like the Medicaid mindset. Remember that Medicaid is jointly financed by the federal and the state government. It covers low-income people or children, the elderly, people with disabilities. There are actually more people who are beneficiaries of the Medicaid program than Medicare. But Medicaid costs the federal government less money. Nevertheless, CBO projects that by 2035, okay, so 10 years out, annual federal spending on Medicaid and CHIP together will total $1 trillion. And Medicaid is very, very much in the hot seat in this Congress. Lots of different policy changes being debated that would reduce funding over the long run. So to discuss, we have an incredible panel. People that have decades of experience both in Congress and the administration. So I am delighted to introduce them to you. We have Brian Blaze, the president of the Paragon Health Institute. Liz Urinka is the operating director of the healthcare policy at the Vistria Group. Allison Orris is a senior fellow and director of Medicaid policy at the Center for Budget and Policy Priorities. And Monica Pop is a partner at the firm Marshall & Pop. Hey, guys, we're in such a moment right now. It's pretty incredible. New administration, new Congress, one party controls both houses and and the executive branch. There are plans for reconciliation that could have significant effects on health programs. Liz, could you start us off? And just it's a very nerdy crowd, but let's ground ourselves in a little bit of common understanding about reconciliation. When Congress is using reconciliation, how does it limit the types of policies that they can address?
Anna, thank you. Thank you for having us. When you say decades of experience, I want everyone to think, no way, that cannot possibly be true. Thank you for having us here. And this is a great opportunity. And I also say that nerds are my favorite. They really are my favorite. It's a good question. So reconciliation, and Anna told me to be brief, which I will not take offense to. But reconciliation is a process and a tool by which originally intended was meant to reconcile kind of what a budget that was set out by Congress in the beginning of the year, at the end of the year, at any point during that fiscal year. The idea was that you would reconcile actual budget spending, revenue, what have you, to fall in line, right, with those expectations. While that is how it originated, that is not how it has been used recently. However, it is only in recent years, probably since 2010, that budget resolution, reconciliation has been seen as more of a partisan exercise. Prior to that, actually, there were very bipartisan bills that were passed through this means. Why is reconciliation helpful or not is a longer conversation we don't have time for, but what it does also allow, in particular in the Senate, is to pass bills with 51 votes. So they are meant to be budgetary in nature. Their primary purpose is again meant to be strictly about numbers rather than policy. And I think I'll pause there.
Yeah, thank you. Thank you for taking the note. I'm being brief. Yeah, it's perfect. Okay, so it's fair to ask, we're talking about reconciliation, but there's so much conversation around Medicaid and reconciliation. Monica, can you please help us understand why this year's reconciliation process has resulted in so much discussion about Medicaid?
So the only, well, first, thank you. Thank you for having me, and I see so many folks in the audience that have been my mentors for so long, so I'm sort of humbled that you're sitting here listening to me today. This is a little wild. I want to push back a little bit, because for over almost 3 decades, Republicans have been trying to reform the Medicaid program. This is not a new exercise for Republicans in any form. I think what this displays is frankly how difficult it is to address Medicaid, which is what I know we'll talk a little bit about today. But for the purposes of the conversation in 2025, I would put this in 2 camps. You have the economic reasons, the budgetary reasons, which, as Anna said, CBO estimates Medicaid spending will hit 5% of GDP in the next 10 years. From a political perspective, President Trump has essentially said Medicare is off the table, or I should say Medicare benefits are off the table. So that certainly limits the ability of Republicans in both the House and the Senate to address deficit reduction as they've committed to the taxpayers based on the November election, as President Trump supports. It limits their ability to look at entitlement programs beyond the Medicaid space, just given the amount of federal spending in that particular program. I think what's going to end up playing out from this point on, today is obviously a very significant day, and going into the weekend in the Senate with a budget vote-a-rama, is that it is one thing to talk about deficit reduction targets. It is an entirely other thing to begin talking about budget policies and how they fit in reconciliation. Because as Liz outlined, the budget reconciliation process is very limiting for actual policy making. Republicans and Democrats have now used it pretty aggressively in partisan forms since 2010. And we all know on both sides of the aisle, I think I've worked with everybody on stage at different points, we all know how difficult it is to perfect policy in a way that makes a difference in the future of entitlement programs, but isn't messy. And so, not only that, you have to get through the Senate parliamentarian, which is a very complicated process, and one that I will not bore you with because there is not enough coffee in the back of that room for me to do that. So just know that we are in a very early phase of the reconciliation process, and while it feels like we're talking about Medicaid, We are not yet talking about Medicaid. We are talking about targeted deficit reduction numbers.
Well, so given all that, given targeted deficit reduction, E&C instructions to, for 880, et cetera, what kinds of policies are being discussed that have momentum? What is on the table for Congress this session? Maybe Allison or Brian, feel free.
Thank you for the invitation to be here. I am a big admirer of the Committee for Responsible Federal Budget, and boy, we do not have a responsible federal budget for many reasons. The lack of spending control in our federal health programs is a big one. And we do have an opportunity right now to address major structural problems with the Medicaid program. Just to start with a data point, I was kind of shocked when I went through and we realized this, but if you go and look at the CBO baselines for Medicaid, and you compare the baseline at the start of the Biden administration with the baseline in January, and you look at it over the next decade, it's $1.2 trillion higher than it was projected to be 4 years ago. So there's been a surge of growth in the Medicaid program for two primary reasons. One, far more enrollees than expected, and part of that is because the Biden administration made it difficult for states to remove people who were no longer eligible for the program. The second, and the subject of a Paragon paper last week, is the tremendous growth of money laundering through the Medicaid program. And by this, I mean the mechanisms by which states create schemes, financing gimmicks, in President Biden's words, scams, in Senator Durbin's words, charades, to maximize the amount that they get through the federal Medicaid program without actually spending anything from the state general fund. As a result of sort of that trend, and I think this is a big issue for those of us that care about the federal budget, the share of Medicaid spending has gone from 60% to 75% over the last few decades. Two main reasons for that. In addition to the increase in money laundering, we can talk more about that problem, and there's been bipartisan support in the past to address a lot of these gimmicks and scams. The ACA Medicaid expansion. The ACA Medicaid expansion presents fundamental problems for program integrity. The federal government reimbursed the entire cost of the population brought on through the ACA, able-bodied working age adults. It's now 90%, but most states don't actually spend the 10%. They've created financing gimmicks so that the program is fully financed. That part of the program is fully financed by the federal government. It's not rocket science what that incentive presents for states. They don't have incentives. They actually make money if they enroll people in the expansion who are eligible for the program under previous eligibility criteria. So we think close to half of expansion enrollees are eligible for the program, but as traditional enrollees, not as eligible under the expansion. And again, the per enrollee cost of the expansion, much higher than expected. If the federal government is bearing the complete cost, states lack any incentives to be wise stewards of those dollars. So I think in terms of what Congress needs to address, they need to address that federal discrimination that exists that favors the able-bodied working age population in Medicaid over the pregnant moms, children, people with disabilities on the program, and they should work to equalize those reimbursement rates. And they should take steps to reduce states' ability to engage in financing schemes, engage in really what amounts to legalized money laundering to maximize federal money without any actual state contribution.
I guess I'll jump in, and again, thank you for having me here. I think before I get to cuts, and I do see some of the policies, being floated now from a slightly different perspective, I just want to sort of take a minute to acknowledge that Medicare doesn't seem to be part of this debate, and Medicaid really does. And yet Medicaid covers 72 million people today. It covers 40% of births, 3 in 5 people in nursing homes. Medicare doesn't cover people in nursing homes.
We have 7 million or so seniors getting their care through Medicaid. And I think that Medicaid has become an increasingly popular program, but the debate in Congress isn't necessarily reflecting that. Rather, we have a situation now where Congress is considering a budget that would partially finance tax cuts by potentially cutting Medicaid. And I agree, the devil will be in the details once the budget resolution passes, once we see what reconciliation legislation looks like. But the debate has been largely about cutting Medicaid in ways that would reduce coverage, reduce benefits, reduce provider payment rates, and impact those people. So I just want to take a minute to sort of talk about the harms that could come. This is, of course, a budget discussion. I agree that sustainability of the Medicaid program is very important, but when we talk about reducing and cutting Medicaid in ways that will lead states to potentially drop their Medicaid expansion, that could reduce coverage by 20 million people. We talked earlier, the first panel was talking about challenges to Medicare's sustainability. If you yank coverage away from people, don't give them coverage throughout their healthy younger years, that doesn't help Medicare either. So whether it's changing legal ways that states are financing their Medicaid program, reducing the matching rate, capping Medicaid spending, which would really fundamentally change the state-federal partnership. I think all of those policies we need to examine from the perspective of what do they do to the people and the providers who are serving Medicaid enrollees. Can I also just say one thing? I feel like we're going to be on like the Senate floor. To my good friend here from Florida. Just a couple things. On the idea that the Biden administration made it more difficult for people to disenroll, the maintenance of effort I think that you're referring to is actually passing a bipartisan line with the Trump administration.
Yeah, that's not what I'm referring to. I'm referring to, so that was part of the Families First coronavirus.
That's right. I'm looking at one.
Yes, but what I'm referring to is the eligibility rules that they have done subsequent to that through regulation that have reduced the frequency that states can do eligibility reviews and made it more difficult for states in how they do eligibility reviews. So I'm talking about Biden administration regulatory actions.
I see. And that you're also talking about the eligibility and enrollment rule that folks are saying should be rescinded.
Yes.
But do you think that states, in looking at unwinding and in looking at the various and sundry systems that had to be put in place, that prioritizing them, fixing those systems to make sure that you have like one door to go through or one eligibility check that accounts over several different programs, does that make more sense or less sense?
Look, so I think there's like IT and figuring out IT and incorporating that and making eligibility determinations based on modern technology makes a great deal of sense. I think the underlying incentive, though, is deeply problematic. If the state bears 0% of the cost, they're getting massive pressure from the healthcare industry, right, not to care about proper enrollment, not to care about whether these expenditures are improving outcomes. And you just have very bad incentives for states. I too want to see a strong federal-state partnership. It has become corrupted. It's been corrupted by the incentives that Washington has provided to states, and that has left us with a very inefficient program that doesn't meet the needs of those that it was intended to serve.
But in that federal and state partnership, right, doesn't it also require CMS, including from 2021, from 2017 through 2021, to approve all of those requested additional, assessments, MCO taxes, provider taxes? Several of those SDPs and things that have been covered in your paper all came about during the Trump administration as well.
Yes, so there is a bipartisan problem at the federal level and the state level with enabling the money laundering to occur. Generally, actually, the administrations have been better on addressing these schemes. So you see the Bush administration try to put policies in place that were going to reduce states' ability to basically engage in a provider tax. And the way that the provider tax works is the provider comes to the state and asks to be taxed. They're like, tax us $1 million and then make a big Medicaid expenditure back on us, and the state will be held harmless, and we'll just get all of this additional money coming in from the federal government through this tax mechanism. The Bush administration tried to crack down on it. It was the one recommendation, that recommendation of the Simpson-Bowles Commission on Medicaid was to phase out states' ability to use provider taxes. President Obama, to his credit, proposed limiting provider taxes. I've been out pretty vocal that Republicans should look and adopt Obama administration proposals right now on Medicaid, and they should adopt the exact proposal that President Obama made in his fiscal year 2013 budget to phase provider taxes down to 3.5%. I think, Congress, unfortunately, is more captured by the industry than the executive branch. So I do think if Congress is unable to act on reducing some of this money laundering and the state-directed payments, which we should get to, I think the administration will try to take steps to reduce some of it. Yeah, I mean the insurer taxes are a new one. We did a paper a couple of weeks ago. California implemented an insurer tax. This tax. So the taxes, they're supposed to be uniform and broad-based, and I'm sorry for getting into complication here. But what that means is, so you're supposed to, the design is to prevent some of the kickbacks that occur. So you would expose non-Medicaid providers to the tax, because they're not going to benefit from the higher Medicaid payment rates that come back through the federal reimbursement. Well, California designed a tax so that the Medicaid insurers pay $200 per month per member, and the commercial insurers pay less than $2 per month, so that the tax is 100 times higher for the Medicaid MCOs, which basically allows this scheme to work, where California can then get all this federal money and pay into the state. And it resulted in the state the next year expanding Medicaid for illegal immigrants and lifting the asset test for Medicaid. So literally in California, you can have unlimited assets and get on the Medicaid program to pay for your long-term care. How is that consistent with a safety net program that prioritizes the most vulnerable when you have no more asset tests in the state of California?
I just want to elevate the conversation a few thousand feet for just a second. I have so much respect for both of you. I think it's important for us to just reflect. One, as Americans, not a Democrat, not a Republican, wishes that Medicaid be the only option for any fellow American. If you do, I sort of challenge you to go to your own physician and really challenge yourself and say, does my physician take Medicaid? And if any of you do go to physicians that take Medicaid, then I actually commend you, because mine don't. I doubt any of yours do. And I think we sort of need to have a conversation around, it probably would not be the case that if today we were designing Medicaid as Republicans and Democrats, that we would design an uncapped federal entitlement program that states can draw down from in a variety of financing schemes. That, Brian is right, that over time the program has become deeply inflated. Access has not necessarily improved. In some cases it has, in others it hasn't. But I think there's a fundamental conversation that could probably occur in a bipartisan room that is more deeply moral about whether or not Americans deserve something better than the Medicaid benefit. That is a conversation that's separate from maybe the one that's happening now in a more partisan exercise. But I also, on the second part of that, I want to say there are only 3 ways to cut the Medicaid program. You either cut eligibility, you cut benefits, or you cut providers. Politically, none of those are really easy to do, which is why every single time we have attempted to reduce Medicaid spending, we have either delayed it in bipartisan form, not accomplished it in partisan or bipartisan form. Now, even when there have been smaller cuts, over time we come back and change that policy. Maybe Wendell or somebody can remind me of like, nope, there's one, right? But very rarely does it occur. And the reason for that is this is not the Medicare program. Medicaid is not made of dials. Medicaid is a much more complex health policy experiment than Medicare will ever dream of being, frankly. And so this is a difficult exercise, not just because it's hard to reach $880 billion over 10, it's because at the end of the day, to Brian and Liz's point, patients depend on this program, but there's an entire network of capitalistic ventures that also benefit from the Medicaid program. And over time, that's become very, very, very complex, weedy, and frankly emotional for complex. And I recognize why.
And I appreciate you saying that Medicaid is so complicated, because I try to explain that to my Medicare friends and they don't get it. But to your point, are there opportunities? Where are the opportunities to invest in sustainability for the Medicaid program? To, improve the program in a way that doesn't end up, with declining access, that doesn't end up moving people off the program unnecessarily. Are there other options that Congress should be looking at for sustainability?
Liz and I were just having a conversation. There are plenty of policies that we could probably at least start with in the transparency side on program integrity. What becomes difficult is when you start talking about program integrity, the devils are in the details, right? And so what are we talking about? Are we talking about how there are financing schemes that states use to draw down dollars to fill what many providers will say are significant gaps in payments from other federal programs, some on the commercial side, or the uninsured or underinsured, right? So this is one of those things where we are always going to try to address the program from a macro scale. We want to reform the program from top to bottom. If you were having a bipartisan conversation, which we are not necessarily having right now in Congress, I think that there could be some steps, but both sides would have to be willing to acknowledge that at the end of the day, the decisions to improve program integrity are going to come with political peril. That is the truth. I saw it in 2017 with my own eyes when I was whipping that ACA repeal bill. It is not an easy exercise, and it really matters according to state.
Yeah.
And I think, just as an example of how complicated this is, at the end of the year, there was a bipartisan package of small Medicaid provisions, nothing that would have saved trillions of dollars, billions of dollars even. One of them had to do with checking people's eligibility better, understanding that sometimes people move and we don't know that. And at the end of the day, my understanding is that CBO didn't score that. That was ensuring that states know where people are is important, but that goes both ways. If you have a better way of sharing data, you can cut people off in one state when they no longer live there so that you limit capitation, but you can also reach out to them in their new state and make sure that they're enrolled, make sure that they see their notices and respond to their notices. So just as an example of the complexity that I think we have to deal with in Medicaid, something that could support program integrity, I don't think necessarily equates to savings in a way that would move the needle much.
I think the other aspect of this, at a very basic level, goes back to this idea of using reconciliation. And it also goes back to this notion that the numbers on a balance sheet are just that, right? A federal cut has incredibly disparate and different impacts on the states. And so that, yes, there can be an absolute dialogue about whether or not it is a cost shift, whether or not the Fed should be paying X, Y, or Z. And we could have a discussion about whether or not it actually is money laundering and illicit versus if you were a publicly traded company and you have a fiduciary responsibility to your shareholders, you don't leave money on the table. Right? These are legal mechanisms by which people or states are drawing down dollars. But I think the other aspect of this is that this is the real world once it gets to the states, not just what's on the balance sheet. So to Monica's point, it's not just the physician, it's not just the state that is sending out or processing claims and sending out checks. This is what happens when you do have a state's budget that has to be balanced either every year, every 2 years, and in the middle of that process, that money starts to change, right? And what then happens? And I think certain states will be better or worse at managing that, whatever that thing is. And so part of it goes back to this idea, what blunt instrument do you have, or are we actually looking for reform? Because originally, again, going back to this idea about why we're talking about reconciliation, it was meant to be a budget tool. And frankly, my good friend from Florida, if we're talking about gimmicks, we could talk about the current policy versus current law baseline. So which I feel like we got it, like, we're going here, okay? So my point is that like, these are different things that we can discuss, but I think at the end
So I
of
don't
the
think
day.
you can infer I support the current.
I was taking notes, I was like, I have gimmicks,
actually-
I have scams, and
I think that I actually don't view this problem as that complicated. I view this problem as, and I think the fact that states have balanced budget requirements is actually a very good reason for conservatives to push more of the Medicaid decisions down to the states, because at the federal government, we have very little budget discipline. The reality is the federal share has dramatically increased in Medicaid spending. It's gone from 60% to 75%. I try to, when I think about policies, it's how can we align incentives so that the decision makers get value from the spending. The Medicaid program has awful incentives. We get such poor value from the spending because states are spending and passing the vast majority of the cost on the margin to the federal government. And I'll end with this one example, and it's the growth of these payments, state-directed payments, and it's that states are now making payments to providers, largely hospital systems, up to average commercial rates through the Medicaid program. Right? Average commercial rates are 2.5 times Medicare rates. It is insanity that the Medicaid payment program is paying 2.5 times what Medicare pays. And it's the natural result of states not having financial skin in the game, where they are now working with the providers who have lots of political power to have many providers getting windfall profits through the Medicaid program. And providers shouldn't be getting windfall profits through the Medicaid program. If that's happening, we have a perverse set of policies that are leading to that. And I think we need to reduce the ability of states to engage in legalized money laundering. I agree, it's mostly legal, right? But it is a scam. In President Biden's words, it's a scam, and we should eliminate it.
Right, I think we're, I'm sorry, please go.
Okay.
Oh, no.
I just, I guess you've spent a lot more time studying SDPs than I have, but I think that safety net hospitals would argue that they are not profiting per se versus trying to close gaps in payment and make themselves more whole for caring for uninsured people, especially in some of the states that haven't expanded Medicaid. So,
Allison, would you mind reminding everyone what SDPs are?
sorry for the acronym. State-directed payments, which is a way that since 2016, states have been able to, and as we've seen a growth in managed care, previously we had a lot of supplemental payments. You may know about EPL payments, upper payment limits, which were made to providers in a fee-for-service universe to help raise their payment levels up to the Medicare rate. As states have moved to managed care, traditionally a state couldn't direct a managed care plan to pay particular providers at particular rates. State-directed payments allow those states to say to a managed care company, pay a provider, pay a hospital for delivering quality services, value-added services. Brian can fill in the details, but the basic idea is to have some accountability for supplemental payments. And the Biden administration's rule, which allowed payments up to the average commercial rate, set that limit. Previously, there was a lot of uncertainty about how high directed payments could go. Set that limit and also added some transparency and accountability. So I think one of the things that will be interested as those rules sort of are rolled out and fully implemented is for us to all learn more about how the payments are being made and what kind of services they're supporting. But I would say, I just focus on the traditional underpayment of Medicaid providers. And while I'm speaking, the other thing some of the comments have prompted is just also a reminder as we're talking about this federal-state partnership with Medicaid and thinking about federal spending in Medicaid, the federal government is also subsidizing the marketplace and Medicare and our own insurer-sponsored employer-sponsored coverage. So again, it kind of takes me back to why are we looking only at Medicaid to pay for some of the other policy
I'm happy to
areas?
talk about reforms to any of those programs. And believe me, I think that Medicare, Congress should look at Medicare, and we've put out a ton of stuff on ways that we can reduce the cost pressure in Medicare. On the directed payments, one of the reasons this got on my radar is I was speaking with investors in New York in the fall, and they want to say the Trump administration's coming in, how can policy change? One of their questions to me was, how long, and they look at hospital financials. So they're seeing how much money hospitals are making through these directed payments on the financials that they insert. And their question was, if the Trump administration comes in, how long is CMS going to allow hospitals to continue committing all of this financial? Their investors, they sort of view this as it's fraud. How long will they allow this fraud to continue? I'm like, well, it's hard to say. We've allowed a lot of fraud and waste and abuse in the Medicaid program over the years, and it's not like the provider tax, sort of this large supplemental payment mechanism, has not been acknowledged for a while. I am surprised at the growth in it over the last several years. CBO told us that it has grown exponentially over the last 2 years in particular.
Yeah, I just want to, real privilege. As a former GAOer, and you might have missed some of this, but Leslie was kind enough to remind our audience that improper payments are not fraud, and that fraud is a willful violation of the law. Okay, sorry, it's on GAO's website, but
the federal government allows it.
payments are
Yes.
illegal.
If in the private sector, you would be in jail if you did what the federal government allows.
But just would also say, and others have made this point, both administrations of both parties have approved provider taxes, have approved directed payments. The first directed payment up to the average commercial rate was actually approved during the first Trump administration. So it does remain to be seen how the administration will deal with it.
Yeah, I know this is not what Brian's trying to say, and he's probably going to hate me for saying this, but it would be disingenuous for me. Thank you. It would be disingenuous for me as a conservative Republican to sit here and tell you I've spent most of my career thinking that a block grant or a per capita cap was the right approach because you need to move this program to the states. That is generally what I learned. It is how I've always thought about it, and in isolation, that is still probably the right approach as a conservative. However, to everyone's point, the financing of the Medicaid program is such that as the federal government takes on a greater and greater share, it is difficult to not have a conversation about whether or not this program is, frankly, a federal program. You can call it a federal state program, but if the state continues to use financing schemes, at some point it becomes a federal program. And that may be to the delight of progressives in the room. I would actually say that then makes Medicaid a dial. And then we will all be in a position where we will be turning down dials for the sake of budget and deficit reduction over time, like we do every single year in the Medicare space. And we could talk about that later, about who likes it and who doesn't like it. As a conservative, I could sort of sit back and think, if I was sort of thinking big thoughts and say, well, maybe it's time for us to actually have a conversation about how do you move Medicaid beneficiaries over to another program using federal funds? Is that a more transparent and cleaner way of funding these benefits? It's probably not time to have that conversation in bipartisan form, but it's coming. As long as these schemes continue, it will force that question.
I think also just, because we keep also talking about incentives, and I think that incentives can go the other way too, right? So to the extent that a state wants to, drive utilization or the use of X, Y, and Z, or fix an access issue, a state can say, I'm going to pay more for that, or I'm willing to pay more for that, right? And so some of this might also be through a state-directed payment, potentially, and we'll know potentially with this, with new transparency, which I agree with. I think it would probably be a good thing, and a lot of people are really interested in understanding just how much a service is actually reimbursed for, right? But the idea that you want to drive participation into a certain area, or pay for performance, or reward quality, these are other incentives that can be used as tools. And I imagine, I don't know what investors you were speaking to, but I mean, I think that folks would like to know, frankly, probably the states, the providers, I'm sure the patients really want to know whether or not their care is still going to be there. But they're saying, tell us what it is that what is the outcome that you want? That's another thing that we have really missed as part of all of this discussion, which is what outcome is it that you're trying to get to? When we know the rules of the road, let us get to that outcome. And I think the challenge is until we have that part of that conversation also, again, we go back to this kind of blunt tool.
You guys don't even need a moderator. This is the best job ever.
I think we might need to mediate you.
Bring a whistle next time.
Yeah.
Let's come back to a couple of things they said. I do want to have one thing that we sort of touched on, but I want to ask directly is more about the role of the states. States have a role here in controlling costs. And with the Medicaid program, that goes both ways. What can states be doing to help ensure that our Medicaid programs nationwide are on a more sustainable path?
Well, they should limit their money laundering that they commit. That's the obvious one, but why would they ever do that, right? So you have to, the federal government needs to come in and change states' incentives so that they look at the program not as a way to grow the economy or a way to just get revenue to providers, but as a way to actually provide efficient and effective health care, and they don't view it that way. States can, think about, it's like Econ 101. If a state is spending its own money on something, it's going to have an incentive to make sure it gets a return worth making that expenditure. If a state is spending money and it's bearing none of the cost, it has no incentive to make sure that it is going to get value from that expense. And that's much more representative of what we have right now with the Medicaid program. So we have a lot of spending that doesn't do anything for our health or improve our outcomes. So the federal government needs to change the incentives that states face.
Can I just say one thing on this? So when I looked at, and I don't have my bag up here, I have Brian's paper with me. It's annotated, and I like a lot of it, actually. I like a lot of it, and I think, and I agree with a lot of it, maybe not all the tone, but I think a lot of what he says is totally right, okay? But what's interesting about it to me, just to say this, and obviously I'd say it to his face, I'm sitting next to him, right? Is this notion that folks are at a universal rate that people are getting rich, or that states are getting rich off the Medicaid program? I have one example. I was looking at the state of Texas at a reimbursement rate for direct care providers, and that reimbursement rate until COVID, where there was a bump up payment, that reimbursement rate to a provider for direct care services was $9 an hour, paid in 15-minute increments. So, and Texas is one of the larger, Texas, Florida, yes, New York, Minnesota's rate is like 1.8% on STPs, but other states use these mechanisms, right? I'm not saying that is good or bad, although I imagine that people would like to have a reimbursement rate that's higher than $9 an hour, and I don't mean it to highlight this one particular state. What I say is, or the reason I'm referencing it, is that the program is typically not what is known to overpay for certain providers. I think it goes back to Marc's point. And so what can states do, right? I think that every 2 years or every year or however often they're looking at their budget, they are looking at how many revenues are coming in, what is their spending, and several states are facing a budget shortfall, right? And then they have to figure out what to do, and when they do that.
Which is good. That's what governing is.
And that is what is currently happening.
You engage in trade-offs.
That's right.
It's not what's happening at the federal level, right? We're running $2 trillion budget.
It's a different conversation.
Well, it's not really. Part of the federal problem is the way states are using the Medicaid program, right? And if you're going to get a handle on the federal budget, you need to address the massive transfers that have gone from the federal government to states. States now get more revenue from the federal government than they get from their own state taxpayers.
I think it's important, though, to not leave this conversation thinking that states don't spend significant parts of their budgets on Medicaid. I think, if I'm remembering this statistic correctly, most states, Medicaid, state funding is the second largest line item after education. It could be different in different states. So yes, there's a lot of federal money going into states, but when we talk about making some of the cuts that we're talking about, states will have to fill those holes, and that's where we worry about reductions in provider rates, which are already too low, or needing to cut optional services, optional benefits. I think states are incentivized to think about efficiency and quality and whether they're getting value for their own dollars. You know, we've seen a lot of states interested in using Section 1115 waivers to consider ways to pursue delivery system reforms, working with the CMS, Center for Medicare and Medicaid Innovation, and some of the Medicaid models. I think all of those are levers that states can pull to drive efficiency and quality.
And of course, 1115 waivers are a type of opportunity for states to waive a whole, for federal governments to waive a whole bunch of requirements and let states remodel their program in a way that hopefully saves some money over time, but often allows them to do some really innovative things.
Can I say one last thing on this? So I don't think anyone would say that average commercial rates is too low, right, for the Medicaid program. But I will say I used to describe Medicaid as a Pac-Man, and Medicaid was crowding out other parts of the state budget, and that is no longer the case. So if you look at Medicaid spending as a share of what the state's actual spending on Medicaid, it's declined over the last few decades. So think about that, the tremendous growth in the program, and actually states spending from their own general fund has declined over time.
Let's shift gears for a moment and think about the administration. You guys have all been part of the administration at one time or another. What kinds of levers does the administration have? You know, we're just starting a new one. They have got 4 years. What do you think is on the menu for this administration when it comes to significant changes to the Medicaid program, and particularly those with an eye towards solvency?
I think Dr. Ross made it pretty clear. Obviously, continued interest in program integrity, certainly looking at some of the financing mechanisms that states are using, will be at the top of their list. One cautionary note, obviously anything the administration does over the next 5 months could have implications for what Congress does in terms of baseline interaction. So I don't expect dramatic policies that reduce federal spending that could potentially have any impact on what Congress is trying to do in this exercise.
So I think you're getting a feel for the administration's position in the ACA program integrity reg that came out a few weeks ago and addresses real problems with the Biden administration's implementation and oversight of the exchanges and sort of the enrollment at any cost position. So I think that's a good sign of what the administration is going to put out, and the seriousness that they're going to address sort of some of the unsustainable nature of our programs. I do think it's very different from term one. I mean, the fiscal situation is much more dire now than it was at the beginning of term one, and there's going to be a lot of pressure to have cost constraints in throughout government, but federal health programs are a huge part of government. I think Monica is generally right, unless Congress comes in and says, well, we're not going to be able to do this, but we can do it if we're going to codify one of your proposed rules, because then we'll have the benefit of saying the administration supports this and Republicans come in and codify it. And I think that is a potential dynamic here as well.
I also agree with Monica's perspective on sort of wait and see for the moment. One of the things that we're watching carefully is both in the congressional debate, do proposals to take coverage away from people who don't meet work requirements in Medicaid advance as part of a legislative effort. We've already seen a number of states asking CMS for authority to do that through a Section 1115 waiver demonstration. The first Trump administration approved those demonstrations to implement work requirements. They were challenged in court, but we've got states lining up. So I think that's another area where I'm concerned that we could see proposals that would reduce coverage rather than broaden coverage.
While we're on the topic, Brian, that you raised about APTCs, I'm getting a lot of questions. So reminder, would you mind saying again, what are the advanced premium tax credits? And do you all see, Brian, you can start, but what do you see is the future for the marketplace plans? And are these on the table on this Congress, especially when it comes to reconciliation?
So the Affordable Care Act created health insurance exchanges, many new rules on health insurance, and created subsidies to make that coverage more affordable for a certain set of consumers. APTC stands for Advanced Premium Tax Credit. People estimate their income at the beginning of the year, and then they get an amount that is advanced to the health insurance company every month that they're enrolled. ACA enrollment was about basically 10 million people a year through 2021. In 2021, Wendell expanded the APTCs. And they made the subsidies more generous for everybody who qualified for one, and they lifted the cap at 4% of the poverty line. So enrollment has spiked. Enrollment has doubled as a result of that. Paragon has done work on problems with the enhanced part of the premium tax credit, particularly, and this gets back to incentives. The subsidies are so large that they made premiums free for people in a certain income range. And what we found is there's a lot more people claiming to have income in that range in many states, particularly my state of Florida, where we have perfected healthcare fraud. And we have 4.5 times as many people enrolled in the exchanges in fully subsidized plans that are eligible for that coverage. But these subsidies, the enhanced part of the subsidies, they expire after 2025, and Congress will have to decide whether to allow them to expire, as I think Congress should, or continue them in some form.
Crystal ball, does anyone want to make predictions about APTCs in this Congress?
I think there are now enough public comments from Senate Republicans to imply that in some form of what Brian has just said is probably viable for a vehicle this year. Whether that's in reconciliation remains to be seen, just purely because of the cost over 10. So whether they do it for 1 or 10 or none in reconciliation is certainly a conversation for the purposes of how things get whipped in a vehicle like this. Obviously, you have a probes moment September 30th. You may have another opportunity in December for a bipartisan exercise of some sort. So I think it remains to be seen, but at this point, it feels like there probably are enough Senate Republicans who have raised concerns about allowing them to lapse permanently.
So, you know, we've talked a lot about Medicaid. We heard a lot about Medicare, but let's add to what they said. What do you think are viable policies that they should be on the table up for discussion in this Congress when it comes to Medicare?
Oh, I mean, to know me is to know how much I detest the 340B program. But without a doubt, there's no reason that Congress should not begin to look at how Medicare overpays for drugs that were purchased at the 340B price, and why Medicare seniors continue to pay for drugs that are so deeply discounted and never makes it into the narrative of drug pricing is beyond me. Obviously, CBO has a proposal that saves $75 billion over 10. I think that there are other ways of defining that particular policy, whether the administration pursues something that is more patient-centered and patient-directed. I think it remains a question too, but it's an opportunity for Congress to open up that particular side. With that said, what will probably open up the Medicare portfolio is, when you start negotiating with members in terms of getting them to vote for things, they all have asks. It's natural, it's part of any process. In this space, it's been publicly reported that there are enough members of the DOC caucus, for example, that would like to see provisions addressing the Medicare physician payment formula. That would open up Medicare, and once you open up Medicare, when it comes over to the Senate, there will start to be a germaneness test, and anything from drug pricing to physician payments to hospitals, that begins to become much more expansive in a debate, especially as it relates to deficit reduction. The one thing I would say is this. With the baseline that Senate Republicans are using right now, you would have to offset any of that additional Medicare spending. And so that adds to complications in terms of vote getting. Depending on what happens with the baseline moving forward as it's negotiated with the House, that could change.
Liz.
Oh, sorry.
Good, Liz.
You go ahead. I'll go after you.
Well, let me ask you a question. So site neutral payments, I mean, that came up in the first panel. It's another perverse feature of government payment policy that we pay more for services in a hospital than we pay in a physician's office. So any move towards site neutral payments that can be done legislatively. There's administrative ways that they can advance site neutral payments. They could expand what ambulatory surgical centers can do. They could get rid of the inpatient only list. Really, those are two actions that the Trump administration took in term one. We think that MA needs reform. So we put out a paper last year. It's one of the most proud papers most proud papers that I am of what Paragon has put out, and we would suggest several significant changes to MA around the benchmarks, around getting at the coding intensity problem, and we propose getting rid of the quality bonus payments. We think the STAR program in Medicare Advantage is virtually meaningless, as well as some Medigap reforms. So we think that is like, it's a policy that recognizes there are advantages of MA, that MA needs reform, and that Republicans should take the opportunity when they are in power to reform MA, rather than, and the analogy that was given, and Wendell will like this analogy, is that Republicans should reform MA when they're in charge, rather than wait until the Democrats are in charge and then do to Part D what happened in the Inflation Reduction Act. So I think, and there is, I think, bipartisan support for MA reform. And then you've got what is going to happen with the Inflation Reduction Act and how the Trump administration will deal with two things. One is this outrageous insurer bailout that the Biden administration did through 402 demo authority to reduce seniors' Part D premiums because they didn't get the Part D redesign right in the Inflation Reduction Act. That is just an outrageous use of administrative authority, but it's a very complicated issue for the Trump administration to deal with. And then what does the administration do with the negotiation power in the Inflation Reduction Act? And do they try to satisfy the president's, really one of his main policy priorities, to reduce the disparity between what Americans pay for pharmaceuticals and what people pay in OECD countries?
Yeah, I mean, I would just say, like I kind of alluded to before, I do agree with Brian on several things. I think that on the issue of site neutral, again, the devil and the angels are in the details, but it is true, right? The idea that you're paying, or excuse me, that a service can be the exact same in two different locations and be paid completely separately, I think from a logical person, pragmatic person's perspective, is kind of head scratching. That said, I go back to my kind of other points before, which is in a vacuum, in a white paper or lit review that my name is on through my work at the Tobin Center, that's all true. In practice, how you ensure that folks have a glide path so that kind of the rug isn't pulled out from underneath them, that is something for lawmakers, for policymakers, for the administration to be thinking about. I also think that transparency in general, whether it's on these SDPs, whether it's on what Medicaid is reimbursing, I think transparency is a huge issue generally. And I think that, the Trump administration the first time around had their entire hospital transparency work. We now have another EO. I think there are a lot of folks that are really interested in that. I know that the previous panel talked about this before. Medicare Advantage. There are lots of different areas for folks to work together. And I will say, having worked for Ron Wyden for 10 years, one of the things that he used to always talk about was how bipartisanship is more likely to have a lasting kind of staying power than when things are done in kind of a knee-jerk way back and forth. I think that's probably true. That said, I think part of the challenge that we're going to have moving forward, just talking about like brass tacks politics, is how much spending or how much kind of collaborative work is possible when we do have kind of the issues that we've been talking about in the beginning of the panel kind of out there, right? Are we able to talk about increasing payments to physicians in the Medicare program if Democrats really believe that individuals and people and, you know, pregnant women, those with disabilities, et cetera, are actually going to have their benefits taken away from them, and the manner in which that is happening. Again, no one has said that to me. Just looking at my, again, if the past is prologue, those are things that we have heard before, right? And I would expect that'll be a question that continues to come up.
And you asked earlier about bipartisan opportunities, and I think at a very high level, if you start to look at all the different sectors that we've talked about, what is slowly happening in a health policy debate is that there is something, you know, we love to throw around bandwagon words like transparency, program integrity, right? But there is something to be said on transparency. And through the populist political lens, whether it's reforming pharmacy benefit management structures, whether it's reforming on drug pricing, how hospitals are paid, or the Medicaid program, or 340B, like I said. What is increasingly happening is that people are questioning the value to them. And that is Republican or Democrat. Yes, we talk about it differently, but when a policy is put through that lens, it is almost impossible to defeat politically, which is why you have seen Republicans and Democrats come together on pharmacy benefit management reform, while you have seen Republicans and Democrats come together on things like site-neutral policies, on drug pricing, and at some point, MA, I think will sort of have that same banner. But I don't know when that day will come for Medicaid, just because it is so politically driven in many, many ways, and the narrative around it is so difficult to break. But it is coming, because you can't continue to expect beneficiaries to have poor access and poor results, while, to Brian's point, the spending just continues to grow. Any logical person can sit down and say, something is wrong with this program. We have to fix it.
I really appreciate that note about bipartisanship. I think that is really, that's why we're here. That is the mission of our organization. It's sort of the same tone of somberness. We've gotten a couple of questions from the audience about the impact of recent changes this week. Lots of layoffs are happening at HHS. In particular, CMS is probably not as hard hit as some of these other agencies. But do you have any thoughts on how reductions in force might affect some of the policies that we've been discussing today?
I mean, you know, on paper, CMS has obviously had a smaller percentage of the cuts. First, let me say, like the panel before, I'm sorry to those who have had significant life changes this week. I worked at HHS. I think many of us can say at some point you have to think about whether or not the government is functioning at its best capability and most efficiently. We can all have a debate about how things were done, but that's not the purpose of today. I do think CMS has been somewhat protected in part. Protected may not be the right word. I'm going to use that word just because mathematically it seems protected, just because of the programs that are involved. And the debate in Congress on Medicaid and Medicare certainly drives that conversation as well. Dr. Oz has a very aggressive agenda on both programs, so I think for right now, CMS seems to be on a sort of more conservative workforce downsize.
I agree, and as a former CMS employee, really reading and watching the news carefully, I understand that folks in the Medicare, Medicaid coordination office, the duals office, have been impacted. To me, that's a real loss. And then I do think thinking about the way that HHS as a whole makes policy is I am concerned that reductions in the Assistant Secretary for Planning and Evaluation, which is sort of the policy shop of HHS, offices that handle data. CMS doesn't operate in isolation, so when we think about the ways that other parts of HHS inform the policy-making process, I think, over time we'll really have a better understanding of the impacts. The Administration for Community Living is another part of HHS that was really decimated. And when you say that they don't do Medicaid, they really do focus on making benefits and services available to people with disabilities, many of whom are receive Medicare and Medicaid. So the interactions, I think, will really, it'll take months to understand, years to understand what's happened this week.
Well, before we wrap, let's just do really quick, for real, 10 seconds, 15 seconds, your crystal ball. You've all been in part of the DC health policy milieu for many years. There's no one better to tell us what do you think will happen. Why don't we just stick to reconciliation? Will reconciliation include major health policy changes? Brian?
Yes.
15 seconds. Liz?
How would you define major? I guess I'm gonna do the Speaker Pelosi magic minute though. But I think on this, I guess my wrap up on this is not just about reconciliation. I think, look, there is the benefit of there being a lot of money, right? Whether it's for savings or others, there's a lot of opportunity. The thing that I am actually very concerned about, whether it's on the layoffs or on states' abilities to manage this, is actually the folks that you want to incentivize to come into a market and make it better start to say, I don't know that I want to do this because it's really uncertain right now, right? So whether you are, if you are trying to professionalize the delivery of something, right? You also have to invest in that person or that entity. And there are lots of different, whether it's a widget or a different profession, right? Folks that choose to be in this amazing, world of healthcare, it is complicated, right? And so the thing I'm actually a little bit concerned about is if we don't kind of recognize or respect that level of complication and say we need certainty or we need some level of durability as opposed to this, again, like the whiplash effect, then folks that kind of could go either way on where they want to spend their time won't do it on healthcare. And that, I think, that's going to hurt us in the long run way more than kind of like originally the knee-jerk reaction of today.
I sort of feel like that should be the last word. My crystal ball is murky. I think that when we think about how quickly Congress is trying to move to make hundreds of billions of dollars of cuts in Medicaid, I think that the devil will be in the details, and at the end of the day, I think members are going to realize that people in their districts will be harmed. So that's my, sort of optimistic hope that we can get past this moment and then have a more bipartisan, outside of reconciliation conversation about healthcare reform.
I do think reconciliation will happen. Do I think it will happen in the numbers that are outlined on paper today? Probably not. There will have to be some negotiations between the two chambers and within the two chambers, just given the nature of the conferences and the margins as they sit. I think President Trump will have to have an enormous amount of influence to drive that Medicaid number to where it is currently outlined in order to be able to get that done, just knowing how difficult it is to get Medicaid cuts done politically. I think it is inevitable that Medicare has to make its way into the conversation if we're talking about some sort of deficit reduction in entitlements. And I would say this, if Republicans fail to do reconciliation this year, I also predict it will be the most expensive tax spending bill in American history. And I cannot imagine what that negotiation would look like. I can see Wendell salivating over there, excited for that moment, but I do not think Republicans will let it get there.
Thank you so much. Wendell feels like you should have been up here. Well, let's take a a moment to thank our panelists. That was absolutely We've heard a lot today about how we can improve health policy, how we can help reduce deficits. We've heard a lot of some division, but some opportunities for bipartisan collaboration. There are doable solutions out there. Remember, last Congress, the House passed the Lower Cost, More Transparency Act, which would have saved money by adjusting site-neutral payments in Medicare and changing rules for pharmacy benefit managers. It can be done. There are things out there that we have agreement on. At the committee, we've invested significant time and resources into these issues because we see real potential for progress. One example is our body of work on Medicaid financing and supplemental payments. We really try to take apart the layers of what is driving this increase over time in supplemental payments. We have a ton of work on Medicare Advantage. In fact, just last week, we published a blog on analyzing MACPAC's most recent data. So for those of you who are really into coding intensity, please check it out. And if you don't know what that means, talk to me after. Before we head out, please note that there is a QR code on the back of your program that will send you directly to our health policy landing page so you can read all of our work on these subjects. Please check back soon because we'll have more papers coming out this month. Well, I don't know about you, but I am convinced that we have the most sophisticated and savvy and knowledgeable health policy experts in this room. So I'm very honored to be part of this entire operation. And I also want to thank our very hardworking staff at CRFP who put so much into making this event. Please join us out in down the hallway for some heavy hors d'oeuvres and drinks. Thank you all very much.